I would like to talk about endovascular treatment and how we can improve the thrombectomy. And I would like to thank Johanna Ospel, one of my PhDs, who also prepared some of the slides. Hey. Nou, verder even kijken. So, of course, very important to improve the EVT results from a patient perspective to get a better functional outcome, but also from a societal perspective, that this will decrease the healthcare cost, as also was demonstrated by Henk van Voorst, who found that 1 minute faster treatment already causes a huge benefit for the society. And how is EVT success defined? By fast, complete reperfusion in first pass, with one pass in the patient. So clearly the success of EVT is time dependent. So this is a graph from the Hermes collaboration. You see the common odds ratio for a good outcome. And you see that the effect of EVT disappears in a relatively unselected population after 7 hours and 20 minutes. And how to be fast? Of course, logistics are very important. And the patient is transferred from the onset to the first primary hospital. And after that, from the primary hospital to the intervention center. And there are many steps who can delay this treatment. But for now, I will focus on the procedure itself. So to get TK2C3 in one pass. In our center, we always try to get the angio suite ready when the patient arrives. And we found that using general anesthesia delays the treatment in many patients and also is not necessary, because many patients are in fact cooperative, and it can also decrease the blood pressure, which can be detrimental for the brain, especially in patients with ischemia. So this is the main goal of our treatment: fast first pass TK2C3 reperfusion. This was an analysis by Zaidat, published in Stroke. There you see here the distribution of the MRS score. This 0 is excellent outcome and 6 is death. And these were patients with a first pass reperfusion compared to non-first pass reperfusion. And you see a big difference in good outcome, almost 30%. Also, we see that the mortality increases when you have more passes, and also when you compare TK2B with 3 or 3C, 2C. So again, fast first pass complete reperfusion should be the primary goal of the treatment. Going back to the TK score, so 0 refers to no perfusion, antegrade, flow beyond the site of occlusion, and 3 to complete perfusion and normal filling of the distal branches. 2C is near complete reperfusion. 2B, substantial perfusion with distal branch filling, more than 50% of the territory visualized. And 1, 2, and 2A are in between. So here you have a lateral view of the different scores. This is the angiography, this anterior, posterior. You see here filling of the anterior branches of the anterior cerebral artery, but no filling of the middle cerebral artery, compared to the TK3, where you see complete filling of the middle cerebral artery branches. And to see, you see a bit limited filling of the very distal branches. And in 2B, you see filling of more than 50%. This is, for instance, 2A, where you see just one MCA branch filling, one M2 branch. This is around 50% or lower. Another study by Al-McAfee, you see the distribution of the MRS score. He had patients who got TICI 2C3 after one pass, and in green and yellow, the good outcome. And even in TICI 3, you see almost 80% good outcome in patients who got a TICI 3. So how we can achieve this goal? It is also dependent on the blood vessels, on the anatomy, the tortuosity, on the characteristics of the thrombus, and importantly also on the tools we have and the techniques used. So let's start with the blood vessels. These vessels can have underlying disease like intracranial artery disease, atherosclerosis. Usually they are much more difficult to pass these stenosis. And sometimes you first have to stent them or do permanent stenting to get a flow through this severe stenosis. And these patients also require antiplatelet therapy to keep these stents open. And this may further also increase the chance of intracranial bleeding. The other thing that can happen is that we see patients with tandem occlusions. So they have both an occlusion in the neck, AP view, you see here the internal carotid artery, there's an occlusion. Then they try to pass this, and then you see here the intracranial occlusion as well. So to reach this occlusion, you first have to pass this occlusion in the neck, either through balloon angioplasty, which may cause additional thrombi, or by placement of a stent and then go directly to the intracranial part. There's still some discussion if you can pass this, if you should stent it immediately or at a later phase, and which occlusion should be treated first, the intracranial one or the neck one. Another important thing is the tortuosity of the vessels. The more tortuous they are, the difficult they are to pass and to reach the intracranial occlusion. So here you see patients with many loops and bends. You can imagine that it's much difficult to get access to the intracranial occlusion with these vessels. So you have many turns like the aortic arch, then the carotid in the neck, then the internal carotid, and even also you can different variations of the aortic arch, called a bovine arch, where the carotid comes from the side of the vessel that goes to the other side. They also found, looking intracranially, when you have many loops and benches of the middle cerebral artery, this also can reduce the success of the reperfusion. And as we know from our own group, from Sarah, she has demonstrated that also the bend of the internal carotid siphon intracranially can heavily impact your treatment, especially when you retrieve the stent. There can be a dislodgement of the clot because the stent struts will open and then the clot can dislodge from your stent, as we see in this case. So now we change gears to the thrombus. Factors related to the thrombus, first the location. So here it's studied by Dutra. She looked at many cases with endovascular treatment with occlusion at the ICA, proximal one or distal one. And there she found that the more distal occlusions, and with distal we mean distal one compared to ICA, you saw better outcomes. Also, the length of the clot plays an important role. Here you see the probability of recanalization versus the length of the occlusion. And you see a clear decline in the probability of recanalization versus lengthy clots. This study evaluated the thrombus volume. And the same, we see the higher the volume of the clot, we have a reverse relationship with the successful recanalization and also with the first pass recanalization. Then the perviousness, also demonstrated by Dutra and published Stroke and by Moken. So perviousness, we mean penetration of the contrast in the clot. And it was also demonstrated that with more pervious thrombi, they are associated with a better clinical outcome and a first pass effect. Then we move to the technique itself. So you can either use stent retrievers or aspiration or combination of both, with or without use of flow rest using a balloon guide catheter. So an example of a straightforward case, we see the non-contrast CT with a hyperdense clot. And here an occlusion of the intracranial carotid T. Here you see clearly in more detail on this coronal CTA. So we injected contrast and we see a clear occlusion here of the carotid T. Then the stent was placed in the clot and it was removed under flow arrest with the balloon inflated on the guide catheter. So here you see the setup where we have here the balloon guide catheter. We use the aspiration syringe when we retrieve the stent. This is the microcatheter and the stent is now in place and is fixed here. So when we pull on the microcatheter, the stent will come back with flow rest on the balloon guide. This is for inflating the balloon. So here we are doing the retrieval. Technician is aspirating. I am pulling on the stent, looking at the image. We see the stent in place with its struts clearly open. Yeah, this should be inflated, but in this case it was just before the inflation. And then we see before and after retrieval with the clot clearly captured in the stent. This is the other technique where you can also use only aspiration. When you look in detail here in this AP view, you see an occlusion of the middle cerebral artery. And here you only see a catheter with a rather big lumen. And we only have to aspirate forcefully. And this is the lateral view where you see here the catheter tip and also no filling of the middle cerebral artery branches. So we aspirate and then we see after one pass complete recanalization of the middle cerebral artery. There's good distal filling of the MCA branches. There are some studies who compared first treatment with the aspiration catheter only or with a stent retriever only, and they claim that the results seem overall non-inferior to stent retrievers. As we also see here in this table, where they use first-line stent retriever in 189 cases, a first-line contact aspiration 192, and you see that the results are almost similar. But what about combined approaches? So when you use the stent retriever and the aspiration catheter and the balloon guide catheter. I must say that I use now this technique almost routinely, because I have the impression that with this technique, in many cases, you get 2C3 just in one pass. So you put the stent retriever in the clot, you deploy the stent, and then this aspiration catheter is also pushed against the clot, and the stent is only a little bit pulled within this aspiration catheter. Then you aspirate both on this catheter and this catheter with the balloon inflated. And in many cases, you get the clot out in one pass. So here you see the study by review by McTaggart. And in blue, you see the double aspiration technique with the stent, which seemed better outcome compared to first-line aspiration alone. And also using the balloon guide catheter, I think it's very important, because then you also have less fragmentation. And thus, if you have fragments, they can easily be aspirated through this big catheter. It has been demonstrated that this use of this balloon catheter will improve clinical outcome, recanalization, and procedure times. Then we have the factors related to the techniques and the tools. And here you have some normal standard stents. And these are stents with a segmented design. And Kaneko has demonstrated that stents with a more segmented design have less stretching, so that in bends, they can better capture the clot, less prone to collapse and more flexible. And they can be beneficial in more tortuous vessels. And this is in fact the Ambertrap stent, and this is the Trevo-like stent. Also, is it important to put your stent as possible in a more straight vessel, like this branch, compared to this one. So when it's straight, it's more likely that you can get the clot out in one pass, like we see here. Another technique to further improve the deployment of the stent is to push on the stent, then so that the struts better open within the clot. You can have better integration of the stent with the clot. Here you see the with active push deployment, good integration with the clot compared to when doing this not. You see that the clot is more in the periphery of the stent. Another thing you can do is that you remove the microcatheter prior to aspiration. So here we are with the distal aspiration catheter, the microcatheter, and the stent wire. And when you remove this before the retrieval and the double aspiration, the lumen of the aspiration will be larger. So you have a higher chance of getting more aspiration power on the clot and here in your catheter. And also another thing is that we don't want to do, that we push or pull the stent too far in this balloon, in this distal access catheter, because you can imagine that then the small thrombi can break off at the point of this aspiration catheter when you pull the stent completely in this catheter. So little pieces can get sheared off. This is the movie from Naravio where you can see this happening. So now they start to pull the stent within the aspiration catheter. And then up. Yeah, they go, see, the fragmentation of the thrombus. And very important, do not forget the human factor. Do you ask your pilot where he has trained and who was his mentor? So, and this is also interesting. This is the simple way where the trainee performs in vivo procedures under supervision and then does his procedures independently as an operator. And then you can see his learning curve. And this is then the risky part when you can have more complications. So we think it's better to first do these procedures with a simulator, then do these procedures in vivo in the supervision, and then become the independent operator. And it will be even better if you do this more often, also when you already are independent operator. You still do these procedures in vitro and look at all the problems that can occur, like a pilot does in the flight simulator. Thus you have the circle of doing in vitro, in vivo, and then independent, sometimes again with your supervisor, and also do this in the simulator. And even better, use individual patient anatomy incorporated in the simulation. So use real patient data, as we have, of course, in INSIST, to further improve these simulations and the procedure. So in summary, to get success of EVT, important factors are the blood vessels, the pipes, the thrombus itself, and the technique. And with that, I would like to thank you for your attention, and also Johanna for assisting in this, making the presentation. Thank you. Are there any questions?
Can I start, Charles?
Yeah.
If you determine the Tiki score of being 2B or 2C, you indicate it's some perfusion or quite some perfusion and so on.
Yeah.
If you want to estimate how much perfusion is there compared to, let's say, the normal state, is there anything to say about this? Or is this more, let's say, an indication of the fact that there is at least a minimal level of perfusion, but not necessarily anything close to physiological?
Yeah, maybe the term perfusion is not the good term for just angiography. Mm-hmm. You only look at the vessels that you see. But if the tissue perfusion is also good, that's the question. You just see filling of the small distal branches. Yeah. For the DSA, we call that then excellent reperfusion if you see all those distal branches. And if you see some not filling distally, 2C, and then you see more than 50%, you call it 2B.
Yeah. And if you do the procedure, are you able to kind of predict the Tiki score? I mean, you retract the thrombus, you feel, okay, this went very well. So this is going to be a Tiki 3. Can you predict it, or do you find that you really feel that you remove the thrombus quite easily, effectively, and then still you see a 2B or 2C?
Yeah, first, it's also shown that the operator usually is rather optimistic. So we found that the score of the operator is usually 10% higher than compared to the core lab. Mm-hmm. And also you do not have many time to decide, because you make one angio, they think, oh, looks like 2C, and then you stop. If you think it's 2A, you have to go on. But then when you go to your reporting room, you have to and then you review your images, and then you see a small distal branch not filling, and then it's factor C, not 3.
Yeah. Okay, thanks. Other questions?
Charles?
Yeah.
Can
Yeah.
you hear me?
I hear you.
So Charles, just wondering about the fracture during aspiration. Do you always see that kind of a mode 2 shear fracture, or do you ever see other kinds of fracture patterns?
Yeah, well, I personally use mainly the bed S technique, so that we use the stent plus the distal aspiration plus the balloon guide. But it's more likely if you have a very stiff clot, which is more adherent to the wall, that you aspirate on the proximal part, you can expect that the distal part can then fragment and fracture and then go distally by the flow.
Oh, okay.
Yeah.
So you do see different patterns. It depends on the composition.
Yeah, I think so. I think it was also demonstrated by your PhD from Neravi. He did some experiments. Yeah. The more friction, the more fragmentation.
Yeah.
Any other questions?
Bruce.
Yeah.
Has a question.
Yeah, hi everybody. Thanks, Charles, for a nice presentation. I was just wondering, how do you choose the treatment technique for a specific patients when patients come to the hospital? So using the stent retriever, aspiration or combination, what's the current criteria for choosing that?
Yeah, there are some characteristics which can guide you to do a certain technique. Like when you have patient come very early with a hyperdense clot, there's usually red blood cell rich, and then only in M1, and you have straight vessels, then it's likely that the clot will go away just with one aspiration. But when you have an older patient with more atherosclerosis and more difficult access, and even some calcified clot, then you can imagine that maybe it's much more difficult. And then you usually try to do the maximum technique to get it still out in one pass.
Can you actually see on the CT scan whether it's a calcified clot or a red blood cell rich clot, or, I mean, how do you know?
Yeah, when it's hyperdense and not calcified, it's more likely red blood cell rich.
But can you see that on the CT scan?
You can see it on
you see that, okay.
in slides. And when it's not hyperdense, it can be platelet rich or fibrin rich. And the calcified are only rare, below 2%. And those are the most difficult to retrieve. But still, it's worthwhile to try to do it.
Mm-hmm.
Yeah.
Thanks. So it depends on the location and composition.
Yeah.
Thanks.
Other questions?
I have one question. Hi, your presentation was very good. Just wanted to ask, as a follow-up after Beruz's question, has in any way, if a patient has already been treated with TPA, would that change your decision in some way?
I saw your presentation. And you saw that there was less friction when the patient was treated with RTPA, eh?
Yeah, okay.
Now, we did the Mr. Clean No IV trial. And the first line was to use stent retriever. And there was a protocol violation when you used aspiration first.
Okay.
But still there were 18% violations. They still use aspiration as first line of defense because they were used to it.
Sure.
And then they found that in the patients who got RTPA, There was no difference with the stent retriever. But in the patients who did not get RTPA, the mortality was much higher in the aspiration group. It was 25% versus 15%.
Sure. Yeah. Yeah.
And we still have to look in detail what's the exact cause of this. I can imagine that the thrombus is more difficult to retrieve when you're not pre-treated with RTPA.
Sure.
And that it can have more friction on the wall.
Absolutely. Yep. That's great. Thanks.
Also, and there was a recent study, it was just accepted in neurology. They say the more passes, the more emboli in new territory. So ENT. And then when it goes to another vessel territory, more distally, you usually cannot retrieve it. They also have a worse outcome. So goal first pass sticky 3.
Okay, clear. Easier said than done, I guess, but clear goal.
Yeah.
Okay, thanks everybody for listening, and thanks Joe for this lecture. Great to hear it.
Thank you, Ed, and thanks for attending.